Stephanie. Let's bring up the first slide here. I understand I'm the last thing between you and freedom here, so I'm going to try and make this entertaining for you, okay? And we're post-lunch, we're post-cocktail, so you're ready for a deeper dive into essentially extreme forms of dry eye. And I mean, this whole symposium has been about dry eye. So maybe you're wondering, why are we talking about neurotropic keratitis? It is almost universally, in my experience, misdiagnosed as dry eye. If you see a lot of dry eye, within your clinic, embedded in it, are probably any number of NK cases, which you may not be recognizing up to this point. And my title, A Simplified Approach to NK Diagnosis and Management, is really meant to convey two things. Number one, this horribly underdiagnosed, misdiagnosed disease, if you understand how to look for it, is easy to spot. You can spot it in seconds at the slit lamp, okay? And because it is not really dry eye and everybody treats it as such, they don't get anywhere with it. Once you understand what you're looking at, the treatment can become very simple. And we're going to get into those two aspects, okay? So my disclosures, I am on the Speakers Bureau Advisory Board, a consultant to, and a principal investigator for all of these entities, two of which are important, Domfe and Claris Bio, which we're going to be talking about their products here, okay? Now, neurotropic keratitis. So what is it? It is a degenerative ocular surface disease secondary to damage related to the sensory loss of the ophthalmic division of the fifth or trigeminal cranial nerve. I'm sure you're all aware of that. Now, damage anywhere along that nerve pathway can result in reduction in corneal sensation as this nerve innervates the cornea. It does, however, take a lot of damage, I mean a lot, before you actually see manifest neurotropic keratitis. Hypoesthesia, loss of sensation, does not equate to neurotropic keratitis. By definition, you have to see the change, the degenerative change on the surface before you qualify as neurotropic keratitis. I'm going to show you, and I specifically asked for the lights to be put out for this presentation. I'm going to show you a lot of clinical material here to try to teach you how to spot this. You're going to see many of my cases. Every one of mine that are presented here have been verified as NK via quantitative corneal sensation testing through Kosheb and aesthesiometry. So they're all a real thing, okay? Now, NK is officially classified as a rare disease, something like 65,000 odd cases in the country. I think this number is extremely underestimating the prevalence. And the reason I say that is it's so commonly, if not almost universally, misdiagnosed. I'm involved in multiple clinical trials in this arena, and I see cases. I've become a troubleshooter for some of the entities that are running these clinical trials, and it's amazing to me how even fellowship-trained cornea specialists are misdiagnosing this disease. So it's just so universal. It's concerning, and that is now changing, though, okay? Etiologies. The classic etiology in all your literature, most common would be in the infectious realm. And specifically, that's in the herpes family, whether it's simplex or zoster. Herpes zoster ophthalmicus, roughly 15 to 20% of your patients getting herpes zoster ophthalmicus ultimately, not necessarily right away, but ultimately will develop NK, okay? Ocular surgery. We all know, I mean, you folks probably co-manage in many cases a refractive surgeon. The refractive surgery, your laser, your LASIK surgery, your keratome cuts the nerves, and then you come in with your excimer laser and fry them, okay? So you lose your sensation that way, and that can trigger NK. What's not mentioned, and in my clinic, and I've been working in this realm research-wise for almost a quarter of a century. In my clinic, the most common source of NK is my local retina surgeon. And they don't know it, they don't believe it until you show them, okay? They're in their own world. I call them paper hangers, okay? They deal with the retina. I like to make a quick joke. I like to tease my retina brethren, if you will. The true purpose of a vitrectomy, I was training in the early era of vitrectomy introduction. We always made jokes as a resident because we had to take care of the post-op vitrectomy cases. True purpose of a vitrectomy is to take a blind eye and make it painful. That's a vitrectomy, okay? Well, they're doing more than that, okay? How does retina surgery cause NK? This is a really nice schematic of the eye, and the cornea is innervated, fifth cranial nerve, a branch of which is the long posterior ciliary nerve. It enters the eye way in the back by the optic nerve and then runs right underneath the retinal pigment epithelium at the 3 and 9 o'clock meridians up to the front of the eye where it innervates the cornea. Okay. Retina surgery, pan-retinal photocoagulation. It's advised that you not laser the 3 and 9 o'clock meridians. Why is that? The laser energy, which is targeting the RPE, heats and fries the RPE, but that nerve runs right underneath. And the heat energy is transmitted not only anteriorly, but posteriorly, and will burn the nerve. And that's how you can get, with pan-retinal photocoagulation, NK. You fry the nerve. How about a scleral buckle? The intent of a buckle is to release traction on the retina by compressing the globe. Well, that's mechanical. You're bending the sclera and all the structures underneath, including the choroid and that long posterior ciliary nerve. And in this case, this image here, a buckle is actually eroded through the sclera, down through and bisected the nerve. So that's how a scleral buckle procedure can cause hypoesthesia or damage to the sensory nerve. And finally, straight vitrectomy, which I just talked about. How do you damage the long posterior ciliary nerve with a vitrectomy? This is a really beautiful photograph here of the long posterior ciliary nerve and the anterior extension of it to the surface, which is called Axenfels loop. You probably all heard that name and seen it with a little pigment around it. Well, what Axenfels loop is anterior extension of the long posterior ciliary nerve in the front of the eye. Where do the retina surgeons, when they do a vitrectomy, they make 3 port incisions, infusion and then their instrumentation, right in that zone. And if they don't pay attention and they punch through with their MVR blade, right through that nerve, they wipe it out. And I've seen florid NK cases just from a simple vitrectomy, and more of them are being done because our retina folks are getting into vitrectomy for floaters. So they're really starting to crank up their surgical volume. And I had the opportunity actually to work exclusively with 2 retina surgeons where all their anterior segment complications came to me. The incidence of NK within their practice was low. We had a very experienced surgeon who had an incidence about 2%. And I'm sorry, the inexperienced, just out of fellowship, 2%, and the experienced gentleman, 1%. But if you're doing hundreds and hundreds of procedures, and especially with their injections now for retinopathy, for macular degeneration, there's a lot of procedures that could cause this damage. So that's how a retina specialist makes my house payments, okay? All right. Now, I mentioned that etiology-wise, the number 1 on the list in virtually all the studies is the infectious, and it's high. But again, I think actually what's not recognized is it's really multifactorial. Multiple insults, each of which lowers the sensation to the point where you cross a threshold and enter into manifest NK. Diabetes is a big one. Diabetes produces peripheral loss of neuropathy, peripheral neuropathy. The 5th cranial nerve is subject to that. I am in the Inland Empire in Southern California, very high Hispanic population, which has a high prevalence of diabetes, very high. So we get a lot of diabetics, they get peripheral neuropathy, and then what else do they get? Proliferative diabetic retinopathy, go to the retina surgeon, get PRP, get a vitrectomy, and get NK. Okay. So multifactorial, I think, at least in my clinic, is the most common cause. Now you get into your post-surgical, your central nervous system, various neurosurgical procedures, acoustic neuromas, trigeminal neuralgias, that can damage the nerve. And finally, what I call your exotics, genetic. These you're going to only see maybe in your pediatric clinics, unusual cause, but they're there, okay? Okay, making the diagnosis, and this is where we're starting to approach the pattern recognition aspect of this presentation. In all the literature with NK, you always get this sequence: diagnostic considerations. Take this really careful history. And I don't do that because they all come in with the wrong diagnosis and they lead me astray and they'll lead you astray. I go at this in complete reversal, okay? I am looking, first of all, and a rule in my clinic, and I understand you folks can't do this really realistically, your ophthalmology clinics can't do it. My rule in my clinic is nobody touches the eye until I see them. Not a tech, not a resident, not a fellow. Nothing goes in the eye until I see them because I want to see it untouched. So I may ask, what brings you in today, Mrs. Jones? And invariably, and I have a big dry eye clinic. We are the tertiary referral center for our entire region for dry eye. I run our center of excellence for dry eye, so I get a lot of dry eye. They all come in, I've got a dry eye, and my doc can't fix it. And I examine them looking for, and what I'm going to show you in just a minute or so here, what I'm looking for. I see something that looks suspicious for NK. Now I haven't put anything in, and now, right now, I can do corneal sensation testing and verify. Whereas if you put drops in, you get a pressure taken, you dilate, you can't accurately do a sensation. You're going to have to bring them back for another visit, okay? So you have to suspect, and then you have to verify. Once I have done that, then I go to the history and pin down why they have it. So I'm going completely opposite of the recommended approach. Corneal sensation testing. Most clinicians don't do it. They feel like it's too much trouble, too much of a hassle, takes too much time. It's really easy. Corey does it. He's doing it a lot, it sounds like. For most clinicians, it's a qualitative process. Okay, you're using maybe a cotton tip. Corey, how do you do yours?
Yeah, I use a cotton tip. It's quick and it's easy. And every single one of my dry patients, I'm checking sensitivity.
Yeah.
I check it in 5. Yeah, so I do it on all my patients, all my dry patients. I use a cotton tip, and I check 4 quadrants and centrally. I always make sure I want to check every region. So for me, it's just to what John said, you're going to find it so much when you actually start looking for it. So every single dry patient I'm doing this on. And
if you're going to do a Q-tip, and I encourage you to do it, spin it up real tight. You may even want to look at it before you test it on the patient to make sure you don't have side fibers coming off. You're going to paint that cornea with that cotton tip. If there's side fibers and they touch the lid or the lashes, it'll trigger a reflexive blink, and you will think they have normal sensation. So spin it really tight. I use Cochet-Bonnet on everybody. I've been doing it for 20 years. This is quantitative, where you actually get numbers, okay? This is the device. It's getting more and more popular. Starting to get hard to get these things. It's not expensive. It's about $500 now, something like that. It's basically just a unit with a slider, a nylon filament. On maximum extension, it goes out 60 millimeters. The longer it goes out, the more flexible it gets. And if they're feeling it, they're very sensitive. You shorten it, it gets stiff. And if they're not feeling it, they're hypoesthetic. The cutoff, remember, max is 60 millimeters, 45 millimeters or higher is considered normal. My group of NK patients, which I have over probably 500 to 600 now in my library, collected over 25 odd years, average is about 5. So it's a profound loss that generates NK. It's not a mild loss. To get to NK, you have to have a big loss. But that can be coupled with your Schirmer scores. If you have like a Sjogren's with extreme low aqueous tear secretion, you don't have to be as hypoesthetic to get the disease. There's a connection between your tear production and your level of anesthesia. Okay. So here now is, for me, this is where I start to drool. I have to wear a lobster bib when I get into this. This is the heart of the talk. This is where I'm going to try to teach you how to spot this disease in seconds. Okay. Call it pattern recognition. I am currently in the process of publishing a paper on this. The images you're about to see, you won't find really in any of the published literature. I'm going to break you into new ground on this, okay? We have to start with the classification scheme for identifying this. And it's very simple. It was presented by a gentleman, Ian Mackey from England back in 1973. Very simple. 3 stages. Stage 1, punctate keratitis. And this is the group by far and away that's the most common. In my clinic, 90% odd of the cases fall into stage 1. And this is the group that's universally misdiagnosed as dry eye. As you drop deeper into hypoesthesia, you get to stage 2, which is a persistent epithelial defect, which will not heal. And if you don't intercept here, you get real dangerous, real serious ulceration, melt. This is where you can perforate and lose the eye. This is a serious disease. Now, stage 1, in all the literature out there, it'll describe stage 1 in terms of how Ian Mackey described it, just punctate keratitis. No location, no pattern. And this is where we depart from the literature, okay? I have identified 5 distinctive variants. Golly spot, what I call central band, what I call blizzard and Milky Way, what I call hurricane and vortex, and finally dendriform. And we're going to want to take a look at these. But all of the stages and all the variants of stage 1, all of them originate from the same location, structural, and pathophysiologic process. And this is where we get into pattern recognition. Our structural components are the corneal epithelium and the subbasal nerve plexus. These 2 structures are both physically and trophically, meaning nutritionally, interdependent, okay? Corneal epithelium produces neuropeptides and nerve growth factor, critical to promoting nerve growth and differentiation and survival. In turn, the nerves produce neuromediators, which are critical to the health of the corneal epithelium. So the 2 are very interdependent. Let's take a closer look, starting with the corneal epithelium. This is a really nice diagrammatic picture of how the corneal epithelium moves in the normal cornea. This is very dynamic structure. Remember, about 5 cell layers thick, that ocular surface epithelium. The whole thing turns over roughly every 6 days. So roughly once a week, the whole thing is turning over, extremely dynamic. All of those new cells are generated by the limbal stem cells, located 360 degrees around the cornea. Those new cells stream, as this diagrammatic picture really nicely shows, they stream radially and centrally, i.e. centripetally. Now, intuitively, you would think they're going to meet at the geographic center of the cornea, the corneal apex. That is not what happens. They actually wind up meeting at a point roughly 2 millimeters below the geographic center. And as they approach that point, which we call the vertex, definition of vertex is the point where lines or circles meet, they start to spin. They start to rotate. Why is that? Okay. A couple of theories, the most compelling of which is the following. There is a known electrical charge differential from the front of the eye to the back of the eye. That charge differential generates a magnetic field. A gentleman named Don Gass, who you probably haven't heard of unless you're in the older category here, iconic figure in the ophthalmic realm, identified, he was also a pathologist besides a retina specialist, identified that were actually ferromagnetic deposits in the corneal epithelium, which would be subject to a magnetic field, and that's what's thought to generate the spin. It's almost always clockwise, 90% of the time, okay? Now, subbasal nerve plexus. This is a true, I don't know how well you can see the detail. This is a real picture of a corneal subbasal nerve plexus, the human plexus, okay? If you look carefully, you see the nerves streaming just like the epithelium does. And as it approaches that corneal vertex, you begin to get the rotation or even a seam formation. And what's happening here, these two structures actually move in tandem together. I think what's happening is the epithelium is virtually dragging the nerves because they innervate, they punch through Bowman's membrane, create a very extensive anastomotic system beneath the epithelial basal cells and Bowman's membrane. And they form ultimately in conjunction with the epithelium, what I call the corneal vertex zone. And this is critical. This is what I call, if you remember only one thing from this whole talk, this is what you remember. This is what I call the NK hot zone. All of NK comes from here. It emanates from here, emanates from this vertex combination of the epithelium and the basal, subbasal nerves. Okay, so let's take a look at some examples. Classic garden variety dry eye, which we've been talking about all day long. It was interesting when the MIBO presentation was being given. One of the clinical studies that they did was corneal staining. And where did they identify that? Inferior cornea. This is where you're most likely to see your punctate keratopathy in a dry eye. And notice something. This is left eye, meaning there's punctum here. The nasal lacrimal duct system is not passive. Every time you blink, it generates a vacuum which will literally suck tears away. That's why you see most of the staining adjacent to the punctum. Okay, that's dry eye. Here comes NK. Different. Not hard to see that that's different. In the hot zone. And I have to make a quick comment. Actually, I'm going to do it in a second. That's NK in a stage 1. But if you don't use fluorescein, you're not going to see it. And I'm surprised, a lot of clinicians don't use fluorescein, okay? You've got to use fluorescein. And here's a great example, one of my patients. This patient looks completely normal, okay? This is a 78-year-old lady with diabetes. She developed proliferative diabetic retinopathy, saw her retina surgeon, got pan-retinal photocoagulation, and had cataract surgery, but winds up with only 20/40 vision, which she is complaining bitterly about. She goes back to her cataract surgeon who says, my surgery is perfect. There's nothing wrong with that. It must be your retina. He sends her to the retina specialist. They do the fluorescein angiogram, the OCT, and conclude your macula looks perfect. Okay, it's not your retina. Must be a neuro-ophthalmologic problem. Let's send you to our neuro-ophthalmologist. Notice how many visits there are and how many docs now, okay? Go to the neuro-ophthalmologist and you know, these are Sherlock Holmes people. It's like, oh, we're gonna figure this one out, okay? I don't understand those folks. That was my least favorite subject as a resident. Scared me. Let's get some imaging, CT scans, MRIs. Everything comes back normal. So what's the problem here? They finally send it to me. And remember my sequence, sit down, what's the problem? I can't see, doc. I've been to blah, 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 blah. Well, okay, let's take a look at you, okay? Put in the fluorescein and what do I see? Bang, there's the answer. How long does that take to figure that out? 2 seconds? Okay. Notice where this is. It's in the hot zone, which involves part of the visual axis. So that's your source of decreased vision and variable vision, because this is going to kind of wax and wane. Okay. Now, so let's now take a look at the 5 variants. Golly spots. Curious, how many people in this room have even heard of golly spots? Ah, okay. We got 2. How many of you have seen Galley spots? Super, Corey, super. Okay, well, what is a Galley spot? Don't worry if you haven't heard of it or seen it. You probably have seen it, but you didn't recognize or realize what you're looking at. Okay, term was originally coined by Jay Galley way back in 1891, actually to describe the lesions he saw in rabbits, okay? The term languished for almost 100 years until 1973, when Ian Mackey of the Mackey classification scheme resurrected it to describe very early findings in NK, okay? He considered it actually the earliest sign of NK, and you will see that those statements propagated through all of the NK literature. What we have found is that it has the least amount of sensory loss, okay, which means it's the most treatment responsive of all the NK variants, okay. These are rare. There's not a lot of them out there. Morphologically, they're very unique, and they're of an evanescent nature. I have seen these come and go in a span of 24 hours without any change in treatment, okay? They present as very discrete, vertically elongated, if not columnar facets of punctate epithelial erosions, okay? Usually located in the NK hot zone. Now, if you try to look up Galley spots in the literature, you'll have a very difficult time finding any clinical images of it. It's just not out there. Here it is. Okay, this is a really nice case. You see these, it's almost raindrop looking, vertical columnar collections of the PEEs. Now, how many of you in the audience have seen something like this? Anybody? Okay, we're picking up a few more. All right. When I first saw this patient, this was a number of years ago, oh, okay, we got an unusual variant of dry eye. And then I literally did a second take, like, wait a minute. Where are all of these lesions located? They're in the hot zone. And I went, oh, okay, maybe I've got an NK here. And I verify with Cochet-Binet testing. And I hit pay dirt. Remember, normal corneal sensation readings, Cochet-Binet, are 45 or higher. The untouched right eye is 60. This eye is 13. Why is that? They've been to their local retina surgeon, okay? They got a macular hole repair with pars plana vitrectomy and endo laser, okay? Very nice example. And again, we're actually in the process of putting together a paper on Galley spots. We're finding out a little bit more about it, but you think of now that you've seen that pattern, be suspicious of NK. Here's your most common one, stage 1 central band K. Here it again, you've seen this before. I've shown you this. There it is. That's classic. Here's another one. You've seen this one. And I got to make a quick comment here. Just a couple of weeks ago, we had our MIBO speaker training in Vegas here, okay? And Bosch and Lohm had a couple of new slide decks that they put together, one of which was a case series. And the very first case that they showed looked just like this, post-LASIK. And a comment that would make it doesn't matter the etiology of the NK, what the source is, they all look the same. In the hot zone, usually doesn't extend to the limbs. But B&L presented this as a dry eye case. And they bantered about back and forth across the room. We had about 125 docs, all of them dry eye specialists. Nobody made any comment about NK until I was sitting in the front row and I couldn't stand it anymore, okay? And I said, I have a different take. This is not dry eye, this is NK. And then the moderators jumped in and said, that's what we think. Corey was in the room. Corey saw this thing come up. Corey, how long did it take you when that thing flashed up for you to think this is NK?
It was immediate.
Immediate, yeah. Less than 2 seconds.
Yeah, as long as it takes for the fluorescein.
Yeah, okay. Corey's been to some of my talks. That's how fast you can get with this. That's how fast you folks are going to be, okay? Classic. Now, and why is that important? Because your standard dry eye therapeutics are not going to work. And you're going to chase your tail That patient's going to come back and back and back. You're going to try all these different things with high expense. You're going to lose the patient. They get tired of it. And here's one. Okay, went through that process. This is what I call blizzard or Milky Way. Now this one, we are getting deeper into hypoesthesia. And I think hopefully you can see, I wish the room was darker. The punctate keratopathy here is now extending pretty much across the entire cornea, okay? This patient had undergone neurosurgery back in 1998, more than a quarter of a century back, acoustic neuroma, and she said to me, immediately after that surgery, my eye started to give me trouble. She had been to countless eye docs. She said they all said the same thing. I had dry eye, but nobody could fix it, okay? She sent to me, I take them through my usual routine, which I have described, put in the fluorescein, take one look, and in 2 seconds, I know what she's got. It hadn't been figured out in 25 years. But how do I figure it out if there's this punctate keratopathy all over the place? Because look where it's most dense. Hot zone. That's the tip-off. It's always the hot zone, okay? Now, this is why I like to call it a Milky Way. There she is. There's the true celestial Milky Way. It's got to be up in the mountains, real clear night to see that, but I think it looks very much like it. I call it the green Milky Way, okay? All right. Now we're going a little deeper. And you won't see these terms anywhere. It's not in the literature. This is all new stuff, okay? Back to the corneal epithelium, and that dynamic movement as it comes to the vertex zone starts to spin, okay? Regular corneal epithelium is transparent and you cannot see that dynamic movement pattern. But if you visualize the epithelium by any means, it will become apparent. There's a whole group of these conditions called cornea verticillata or vortex keratopathy, where you have visualized the epithelium through drug deposit or disease. This is the classic verticillata, it's Fabry's disease, sphingolipidoses, excess deposited into the epithelium, allowing you to visualize it, and there is that radial centripetal movement pattern collecting down in the corneal vertex zone with spin. So what this shows you is all corneal epithelium follows the same movement pattern. All of these now are non-staining. The staining version is a little different and was only recently identified. This is a hurricane keratopathy. The term was developed or launched in the 1980s by a corneal surgeon doing a lot of transplants and identified this process in many of his immediate post-op transplant patients. But his thinking was this lit up with fluorescein and was present because of the heavy steroids they were giving at the end of the surgery, okay? Call this hurricane keratopathy. And this finding was validated in multiple papers later on. We identified way back in 2000, I think it was 4, this was an ARVO presentation, that staining vortex keratopathy was very commonly associated with NK. In fact, basically pathognomonic. We had about 70 cases of staining vortex keratopathy, and 80% of them were NK, okay? I don't know how well you can see that hurricane pattern here. It's almost flower-like. Let's go up on MAG. Now you start to see that streaming radiality and then collecting with the spin down in the vertex zone, okay? Here's an even more florid one. This is a Ratten filter. I was not a big fan of Ratten filters until I started doing a lot of clinical trials and realized how much more detail you get with a Ratten filter. It's just a yellow filter. But look at, look at the floridity of this. Streaming, the rotation. That's a florid hurricane keratopathy, okay? And then finally, the last of the 5 in the stage 1, dendriform. Yeah, nice schematic drawing. You can get a variation on the hurricane where you get dendriform type arms to the rotational process, okay? What's a great clinical example of that? Amiodarone keratopathy. Every patient on amiodarone will get this deposit, but in almost all cases, it's so mild, clinically doesn't matter. This patient was on high dose amiodarone. This is a 4+ florid, was affecting vision, but you can see I hope that that dendritiform pattern, and why is that important to identify in these NK cases? Because the clinician will think it's infectious herpes and will treat it. And invariably, they will treat it with a topical antiviral like Viroptic, which is super toxic. And the patient won't get any better, so they keep pouring it on until they finally literally will keratinize the whole surface, toxify it completely. And then it takes me months to undo that. Here's the real thing, and there's easy ways to differentiate this. This is active herpes simplex keratitis. The lesions are randomly distributed across the cornea, randomly oriented. They have dichotomous branching. They have terminal end bulbs. And here's a real nice key tip off. They're not sitting in a big field of punctate keratopathy. They are discrete. Let's take a look at some dendriform examples of NK. Here's an early one. You see little branching radiality, which can look kind of like, suspiciously like maybe a healing dendrite, but it's sitting in a big field of punctate keratopathy. And it's always the same way, oriented horizontally elongated in the NK hot zone, okay? Here's another one. Again, horizontally elongated, got a little dendritiform pattern here, but in that hot zone and sitting in a big field of punctate keratopathy. Here's a real tough one. This one could fool you. Take a look at this. Looks like dichotomous branching, maybe end bulbs, but look at the configuration. Horizontally oval elongated, sitting in the hot zone, sitting in a big field of punctate keratopathy. You put all those things together and it gets easy, okay? And a final one here, this is a real hurricane looking one. Dendriform or hurricane. This looks like a satellite photo of some of our recent hurricanes with the Ratten filter. Beautiful example. This patient has been in 3 different clinical trials for NK, a real tough one for me, okay? Now, hurricane and dendriform are just one incremental step away from the next stage, stage 2. And this is not my patient, but it's a beautiful example of stage 2. Hot zone, horizontally oval elongated, loss of epithelium, rolled edges. That's this thing trying to heal and it can't do it. But take a look at something else. Look at what's coming off here, little radial lines. This was a dendriform. And as you heal this, you'll go back through the stage 1 phases, dendriform, hurricane, or less. And these things will wax and wane if they're not treated properly. You can go in and out of a stage 1 to a stage 2, stage 3. You can go in and out of those. Here's another one, a stage 2 epidefect, but look at all the hurricane radiality coming out of it, okay? So hurricane and dendriform, just an incremental step away from the dangerous stage 2. And finally, real serious stage 3. You can see by this slit lamp photo, we're excavating, we're ulcerated. Nice, juicy central ulcer with a collar, if you will, almost dendritiform lesions sitting in a big field of punctate keratopathy. Almost looks like a bullseye, okay? But you see how this is all coming to you virtually in the same way, same location, same pattern, over and over again. That's how you get to recognize this instantly. And finally, an extreme stage 3, we're down to a desmetocele here, but look at the location, look at the orientation and the shape. This patient is like one sneeze, cough, bump away from blowing that out, everything coming out and losing the eye. Okay, that's an emergency transplant right there. Okay. Speaking of transplant, so how do we treat this? The classic treatment algorithms here, starting with topicals. Everybody says, got to use artificial tears, non-preserved. It's just not going to do anything, but you do it anyway. You got to lubricate. Okay. Steroids. If you have a infectious-based condition from herpes zoster or simplex, they can have interstitial keratitis, a chronic inflammatory condition. A neurotropic surface is extremely fragile, and any stressor, like inflammation, will cause it to just, the surface to blow off. Autologous serum, a lot of people really like that. I don't. I haven't had a lot of success with it. And if you do heal one of these lesions with this, you're really walking on eggshells because it hasn't addressed the underlying loss of sensation. And you can very easily, with a single, the next stressor, take you right back into disease. Antibiotics you do use, I use on stage 2 and 3 because you don't want them infected. If they get infected, they are incredibly difficult to treat. And I'll give you one teaser here real quick. A great example of an infected neurotropic ulcer comes from something called methamphetamine keratitis. You guys have a meth problem out here? We do. We got a big one. You won't recognize it unless you do a drug screen on these people because they all deny it. But they come in infected. And what we've identified is they're also neurotropic. 50% of them will perforate, despite you getting the right bug and giving them the right fortified antibiotics. Why do they do that? Because they're also neurotropic. Okay. In-office procedures, bandage lenses have some benefit, especially in extreme cases. Punctal occlusion is the one, that was my go-to, aggressive punctal occlusion until a couple of years ago, and I'll tell you when that changed. But I mean aggressive. Plugs usually don't do the job. Cautery. You got to completely seal. We do 1 to 2 cauteries per day in my clinic, okay? Non-surgical eyelid closure, that's Botox, drops the lid down. It may work until the Botox wears off. Amniotic membranes, lots of people like that. I don't go there because I've had a lot of failures with that. And even if you heal, just like serum tears, you're still prone to the disease recurring. Tissue adhesives is glue. Well, that's if you're about to perf or you're perfed, and that doesn't solve the NK. You're just salvaging the globe at that point. And finally, surgical intervention, tarsorrhaphy works, but patients hate it, okay? If you get into the lag ophthalmos, like a 7th palsy, that's the only place to go to tarsorrhaphy. Conjunctival flap, rare. You don't get any useful vision, but it'll preserve an eye. We just did one a couple of days ago while I was on emergency call. Really bad one. Corneal transplants, all you're doing is salvaging that globe because you haven't done anything. In fact, you may have made the NK worse because you've now cut all the nerves with your transplant, and they're going to go right down the same rabbit hole they just came from, okay? And finally, nerve transplantation, a lot of interest in that. Takes an oculoplastic specialist to do that. It's very difficult, and the results have been pretty problematic. The title of my talk was Simplifying the Diagnosis, which I hope I have done for you, and simplifying the treatment. And how do I do that? We'll get into the molecular pathophysiology. That's the key. Nerve growth factor. Nerve growth factor is thought to support the corneal surface integrity through 3 separate mechanisms. Corneal innervation, it grows nerves. It enhances reflex tear secretion, and it promotes epithelial cell proliferation, differentiation, and survival. That makes it epithelial tropic, okay? That's endogenous nerve growth factor. The lady that discovered that got the medal, I'm sorry, Nobel. She got the Nobel for it. Okay. Which takes us to synergimin. What is that? That's the active ingredient in oxyrvate. It is recombinant human nerve growth factor. It's the very first topical biologic we've ever had in the eye history, approved by the FDA in 2018 for treatment of all 3 stages of NK, accorded orphan drug status, and the FDA deemed it breakthrough therapy. They were so impressed with the clinical trial results. What is synergimin? It is, structurally identical. Oh, we're going backwards here. Let's go to, it's structurally identical to endogenous nerve growth factor. Now, let's take a quick look at the oxyrvate clinical trials. There were 2 European study of 156 patients and the US study with 48. We were one of the sites. I was the PI on that. To get into the study, you had to have stage 2 and stage 3 NK. You were treated with either drug or vehicle for 8 weeks, which is the standard therapy for it. European study ran afterwards 1 year follow-up. We ran 6 months follow-up. The primary endpoint was what proportion of stage 2 and stage 3 NK lesions healed completely by the end of the 8 weeks. And here's the results. European study, American study. At the end of 4 weeks, the midway point, more than half of the patients in both groups fully healed. By the end of 8 weeks, about 3/4 of the European and 2/3 of the US totally healed. Very impressive results. That's why the FDA expedited its release and declared it breakthrough therapy. Now, that also means that you don't heal 100% of these cases. What do you do with those? And we're still trying to figure out what is it about that group that renders them resistant to the oxybate. I haven't figured that out yet. But what do? I hit them again. Second round of oxybate, third round of oxybate. I don't hesitate, okay? How long does the effect last? Let's look at the European study, follow their patients a full year. At the end of the year, 80% of the patients that originally healed remain healed, very high numbers. What do you do with the 20% that recur? Hit them again, okay? All right. I'm going to show you 3 case studies now, each of which has something different to add to this conversation. Start with our old friend, Golly spots, okay? So I figured out this was an NK case, got them on oxybate. They healed completely in 3 days. I ran the whole 8-week course. Patient never had a recurrence. I continue to follow him this day. I made the comment, Golly spots has the least amount of sensory loss, therefore the most treatment sensitive. In this case, really demonstrated that beautifully. 3 days, the whole thing is gone, okay? Now this one, this is an interesting one. This is a gentleman, his name was Norman. Really enjoyed him as a patient. He's got a great sense of humor. Came into me with real severe herpes zoster ophthalmicus in his left eye. He had ocular surface involvement with pseudodendrites. He had endotheliitis, so his cornea was really involved. Now, after he recovered from the acute phase, he had a staining pattern that made me suspicious for stage 1 NK, but I did Cochet-Bonnet on him and he came in at 45. So I concluded he's not NK, he's just a dry eye, and I put a plug in him. Brought him back in 2 months. 2 months later, he comes back, he's lost his plug. I replug him, bring him back in another 2 months. And I remember to this day, walking in the room, I'm gonna pretend Corey is my patient here. And I have a heavy clinic. I have to see patients every 10 minutes. So I walk in the door and the first thing I do is just check things out. Like, are they happy? Are they sad? Is this gonna be easy or is this gonna be a hard one, okay? And Norman's sitting there just looking at me with a grin on his face. And I go, Norman, how you doing? He goes, great, doc. And I go like, this is gonna be easy, okay? So I pull up the chair at the slit lamp, take a look at him, and about fell off the back of the chair, okay? Look at this. This is a advanced stage 3 neurotropic ulcer. And Norman is looking at me, he didn't know anything's wrong. That's what's so scary about this. Also notice that the lesion is lower than the usual hot zone. Norman has a ptosis and it's shifting his whole frame downward. I check his corneal sensation and it has gone from 45 to 7 in 4 months, indicating there's been a slow burn disease process, subclinical, no skin eruptions or anything. And actually there is a clinical trial underway right now called ZEDS, looking at prophylactic treatment of acyclovir for these cases. We're getting the results this Wednesday. It's coming out this Wednesday. I can't wait. Okay, we're in that trial. At any rate, I mean, I look at Norman like, oh my God. So I put a new plug in, order the oxybate, put them on Moxie so there's no infection, emicin ointment for lots of lubrication and protection, and acyclovir full infectious dose, because I don't know if anything's going on there or not. It's not going to hurt him. Comes back 2 weeks later, no better, no worse, but no better. I put a bandage lens on him, and this is the day that he gets his oxybate. So now he's getting oxybate on top of a contact lens. Domphy Pharmaceuticals in their insert, package insert, will say, do not use oxybate with a bandage lens, okay? They're concerned that will interfere with the distribution of the drug. We're doing it anyway because I'm scared here. I don't want this guy to perf, okay? He comes back just 5 days later, I'm following him close, and he is almost 100% healed in 5 days, okay? I didn't have a picture at that point, but I caught him 11 days out, and this is what he looked like. So he's got a lot of punctate keratopathy where that also was, but he's healed. Question?
Yeah, why did you decide to go with the bandage lens as opposed to like amniotic
Oh.
membrane? Because I can't imagine it would have sat very well on that with the bandage lens.
Yeah, great question. How about amniotic membrane? I have no problem at all using oxybate over an amniotic membrane. I've never tried it, but if you want to do it, I would encourage you to do it because I think it'll work. Why did the bandage, first of all, the bandage lens stayed on very nicely, but you're not supposed to do it. Why did I choose to do a bandage lens in the first place? Because I was doing everything I could so that thing wouldn't progress and perf. Why did he do so well? And I mean, do well? The European study, 156 patients, and they tracked how long it took to heal. Put Norman in there. He's patient number 157. He comes in at number 1 fastest, the fastest out of 157 patients. Why is that? I think what's going on is the lens acts as a drug depot, reservoir, time releasing the agent so they get more of it. And there's actually a paper out there now describing successful use of bandage lenses in these more extreme cases. So you can do it. And if you want to do amniotic membrane, I encourage you to do it. Okay. Okay. Final case. Here we go. This is a 59-year-old Caucasian male practicing dentist. Okay. And this is a great example of some of the futility in some of these treatment procedures that I have already talked about and why I don't like them. He had shingles 22 years prior, comes in with this neurotropic ulcer, and he has been treated by not 1, but 2 well-trained cornea fellowship-trained specialists. And look at all they've thrown at him. Copious preservative-free artificial tears, Moxie, so he doesn't get infected, ointment Q2 hours, and topical FML. He's got interstitial keratitis from his shingles. He's a steroid responder, so he gets timolol. Mistake. Why is that? There's a subset of the population that responds to topical beta blockers as an anesthetic. It's in your older population. Don't use a beta blocker and a neurotropic cornea. You may make it worse. He's had multiple punctal plugs, serial bandage lenses, and serial amniotic membrane. Didn't work. Didn't have my Gaucher-Bonnet, test him with a Q-tip. He's absent. We take him to surgery 3 days later, and this is what he looks like. This is a desmetocele. Again, he's a cough, a bump, a sneeze away from blowing the eye out and losing it. My hair was brown when I started this case. It turned white at the end of it, okay? Just one wrong move, he perfs, everything comes out, and that surgery gets really technically difficult. Here he is day 1, post-op day 1, looking pretty good. But a total epithelial defect, which is not unusual, okay? But I know he's neurotropic, and this is not going to want to heal. So I put a bandage lens on him, and we order the oxybate, okay? Now he comes back a week later, and lo and behold, he has fully healed. I was surprised, but I'll take it, okay? But at this point, we get the oxybate, continue the bandage lens for 1 more week with the oxybate, complete the 8-week course of the oxybate. Here he is, month 2, the end of the oxybate. No ocular surface disturbance whatsoever, not even stage 1. Uncorrected visual acuity 20/40 at month 2. Doing really well. Here he is, 2.5 years later, continued to do very well, never had any ocular surface issues thereafter. Taught me a lesson. Any NK case that I'm contemplating surgery on, I pre-treat with oxybate, because otherwise you'll turn them into, it will recur and get bad again. Now, just to try and wrap this up, oxybate actually just represents the first generation of epitheliotropic NK agents, but it's opened the door to the whole next generation, which is coming. These are all active clinical trials that we're running at Loma Linda right now. Hepatocyte growth factor, mesenchymal stem cell, secretome, Regentry, and Domfi folks have now launched a second clinical trial looking strictly at stage 3s because they think it may promote wound healing, rebuilding stroma, okay? So that's what's going on. But what this has also done in the process of running these clinical trials, we've now discovered there are additional benefits to these epitheliotropic agents. And one of them appears to be the next new queen of the ocular surface realm, limbal stem cell deficiency. What we are now uncovering is that limbal stem cell and NK can be coexistent diseases. In one of our current clinical trials, we identified limbal stem cell in 40% of our stage 2 and stage 3 NK cases. So these diseases run together. This is the stage 2 NK, and identifying limbal stem cell is a pattern recognition process unto its own, and it's a whole separate lecture. It's really important ultimately for you folks to learn how to identify this because 20 to 30% of limbal stem cell cases come from contact lens overwear. So you folks are front line in this disease, okay? Now I want to show you something. This patient, and let's see if I can back this up, treated her for a year and a half with everything I could think of, including 2 rounds of Oxervate with no clinical effect whatsoever. Entered her into the hepatocyte growth factor, 8 weeks treatment. We don't know what she's got. Did she get the drug? Did she get the vehicle? I'll bet the farm she got the drug because she healed at stage 2 in the 8 weeks and nothing would touch that before. But the total limbal stem cell remained. Now, much to our surprise as I followed her, 4 months after completing the trial, look at the limbal stem cell. It has regressed to a stage 1. Vision went from 2200 to 2040. This is the sentinel case, the first case that I know of in the country where a pharmacologic approach was used to successfully treat stage 3 limbal stem cell deficiency. Up to now, the only way you could treat these with transplant, limbal stem cell transplant surgery, which is very problematic, with problematic results. Okay, this is the first. And this case, here's a comparison, the end of the 8 weeks, end of 4 months after treatment to show you the difference. This case has launched a whole new industry. We have just started to enroll patients in a limbal stem cell trial using hepatocyte growth factor, okay? This is the study itself. We have 5 sites. We're one of them, but we launched it with this case. And other epitheliotropic agents are beginning to look at doing the same thing. This is a whole new industry. Limbal stem cell, by the way, is an even worse disease than NK. You put the two together, you really got a problem. And finally, this is the end of the talk. The same hepatocyte growth factor has anti-fibrotic activity. We have launched a clinical trial looking at scar reversal. Never been done before, okay? Not old scars, but fresh scars, like a contact lens related keratitis. Okay, and we're loaded with that at Loma Linda.